Hydrocephalus affects both pediatric and adults. The incidence is around 3 to 5 per thousand live births, and the peak age of presentation is at 1 week of life and then 4 to 8 years of age. It is one of the common developmental disability and the number one cause of brain surgery for children in the United States. Hydrocephalus is the excessive accumulation of CSF in the ventricles or the cavities of the brain. The normal CSF volume is about 40 to 60 ml in infants, 60 to 100 in young children, and about 140 to 150 ml in adults. Now, CSF is produced mainly by the choroid plexus of the ventricles at the rate of 0.35 to 0.40 milliliter per minute, that is around 500 to 600 ml per day. However, most of it is reabsorbed and around 140 to 150 ml is circulating at any given point of time in case of adults. The CSF circulates from the lateral ventricle to the third ventricle through the foramen of Monro, and then through the aqueduct of Sylvius to the fourth ventricle, and then to the subarachnoid space through foramen of Lasca and Magendie. As we said earlier, 85 to 90% of CSF is reabsorbed in the cranium by the arachnoid villi and arachnoid granulations at dural walls, superior sagittal sinus, and venous lacunae. Now, if there is any disbalance between the production and absorption of the CSF, maybe because of increased production or decreased reabsorption, there will be ventriculomegaly. Now, hydrocephalus may be classified as communicating and non-communicating. Communicating is due to decreased reabsorption by the arachnoid villi, such as in case of ventriculitis or arachnoiditis, or intraventricular hemorrhage, which most commonly follows a subarachnoid hemorrhage in a premature infant. Now, the non-communicating hydrocephalus is due to obstruction at or proximal to the foramen of Lasca and Magendie, which is maybe due to space-occupying lesions such as cysts and tumors, or due to infection and hemorrhage, or because of congenital malformations and aqueductal stenosis. The hydrocephalus may be congenital, in which case the hydrocephalus will present within a few months of life, or it may be due to acquired causes such as infection, head trauma, tumors, and intraventricular hemorrhage. There are some special types of hydrocephalus such as normal pressure hydrocephalus, which is usually seen in the elderly and which may result from the subarachnoid hemorrhage. There is another special type of hydrocephalus known as hydrocephalus ex vacuo, occurs following traumatic brain injury or stroke. The signs and symptoms of hydrocephalus varies with age, the cause, and then the disease progression. Example, infants with open fontanelle versus the adults will have different signs and symptoms. In newborn and infants, the fontanelle bulge, unusually large head, rapid increase in head size, or there may be vomiting, sleepiness, irritability, shrill cry, downward deviation of eyes, that is known as the sunset sign, or may present with seizure. Messi Wayne signs is usually positive, that is the cracked pot sign. If you tap the child's head and at the same time listen with your stethoscope, you will hear a sound of a cracked pot. That is known as Messi Wayne sign. In case of older children and in adults, there may be features of increased ICP such as nausea, vomiting, papilledema. There may be growth retardation, poor coordination, gait disturbances, urinary incontinence, lethargy, drowsiness, irritability as well, cognitive decline, and memory loss. Signs and symptoms in the normal pressure hydrocephalus is usually problem in walking, impaired bladder control, or progressive dementia and hyponatremia. Hydrocephalus may be diagnosed by clinical neurological evaluation such as serial recording of the head circumference, especially in infants, which will show an increase of more than 1 centimeter every 2 weeks in the first 3 months of life. The next thing you can do is cranial imaging using the ultrasonography or the CAT scan. You can also do ICP monitoring. Now, the treatment of hydrocephalus is mainly surgical. There are different shunting procedures such as ventriculoperitoneal, ventriculoatrial, ventriculopleural, or ventriculojacular shunts. Other surgical options include endoscopic third ventriculostomy in case of obstructive hydrocephalus and then external ventricular drainage EVD. The shunts are classified as a low, medium, and high pressure shunts according to the opening pressure of the unidirectional valve. The proximal end of the shunt is placed in either the frontal, the parietal, or posterior horn of lateral ventricle. Now, the valve is for unidirectional flow, so CSF does not come back, and then the distal end is placed either in the peritoneum or any other absorptive surface as discussed earlier. Now, coming to the pre-op assessment of patient posted for VP shunt, history will include history that is common to all surgery under general anesthesia, which will include the birth history, like whether the baby was premature or not, were there any birth trauma, was it a case of forceps delivery, or immunization history, history of allergy, history of problem with previous anesthesia surgery, if any, and then last oral intake, especially in emergency procedures. And we would also ask something about the hydrocephalus, the drug history, whether anticonvulsant is being used or not, if used, what drug and at what dose, and the use of diuretics or acetazolamide, and then associated congenital anomalies, the cardiac anomalies or the respiratory anomalies, if any history of fever, which might suggest a case of meningitis, and then history of recurrent respiratory infection due to decreased sensorium and aspiration, history of nausea, vomiting, headache, which will suggest raised ICP, and then any previous history of convulsion. We would have a general examination of the patient, which may reveal that the patient has poor general condition, and then the patient may be volume depleted, and dehydration and electrolyte imbalance may be seen due to prolonged vomiting and poor oral feeding, and then we would search for the presence of any other congenital anomaly. And then we would assess for the difficult airway, because The patient will have a big head, supposedly, especially in infants and children. And as we are dealing with infants, they will be edentulous, and then CSF and respiratory system examinations, especially about the congenital anomalies. And then we would especially look for cranial nerve palsy or features of raised ICP, and then any signs of brainstem involvement. The routine investigations, including the complete hemogram, the hemoglobin coagulation profile, renal function and electrolytes, and then the chest x-ray. We would like to order some special investigations such as x-ray skull or CT scan or MRI, and then echo to evaluate the congenital heart disease if clinically suspected. As part of the pre-op optimization and preparation, we would like to improve the nutrition if it is a case of elective surgery. We will not have time if it is a case of emergency surgery. And then we would like to correct the fluid and electrolyte imbalance, which is expected in case of hydrocephalus patients, and treat any RTI with antibiotic. And if there is a raised ICP, we'd like to reduce that to the optimum by giving diuretics. As part of the pre-med, we would like to avoid the sedatives because there may be exacerbation or mask of the neurological dysfunction because of sedation, and then the patient may have apneic spell or there may be depression of ventilation. So until and unless it is absolutely necessary, we would like to avoid sedatives, especially in the presence of raised ICP. The anesthetic challenges faced during operation of hydrocephalus include managing a pediatric patient with all the airway challenges and difficult intubation. Now, complications related to a full stomach, and then a risk of accidental extubation or displacement during burr hole surgery or tunneling. And then there is a risk of accidental pneumothorax during tunneling. And then managing the raised ICP is also a challenge. The goals of anesthesia include avoiding any further rise in ICP, and then to maintain hemodynamic stability, avoid hypoxia, hypercarbia, and hypothermia. We should aim for a smooth post-operative recovery. Intravenous induction is preferred in case of a raised ICP over inhalational. Now, thiopenton at the dose of 4 to 7 mg per kg is most commonly used. Propofol at the dose of 2 to 4 mg per kg can also be used. We should avoid ketamine. If there is no signs of raised ICP, inhaled induction can also be used, in which case sevoflurane is most commonly used. Since halotane increases the ICP, we better avoid that. Non-depolarizing muscle relaxant is preferred. Among NDMRs, atacurium is the preferred drug because the surgery is relatively short, and since vecuronium can cause bradycardia, we would try to avoid that. Here are some pointers on how to intubate this pediatric patient undergoing hydrocephalus surgery. That include to support the head with a donut may be placed under the head, or the assistant may support the head. There is the chance of difficult intubation due to the large head, and proper positioning may be difficult. The positioning by placing the child over a pillow and allowing the head to lie just outside the pillow may help. And then the tube should be firmly secured, as there is a chance of accidental extubation due to head rotation during surgery. And then oropharyngeal packing should be given to secure the tube in position, because the child's head will be rotated here and there during the surgery. Anesthesia should be maintained with oxygen, air, and volatile agent. We would not use nitrous oxide here because it will increase cerebral blood flow, and then that will increase the ICP. Also, nitrous oxide has a strong emetic effect. It may confuse the patient evaluation post-operatively. There is also a chance of air embolism in the diploic vein. And then spontaneous ventilation is not recommended during hydrocephalus surgery because of the risk of air embolism during craniotomy, and then ventilatory depression, if present, can cause hypercarbia, which then will raise the ICP. We would rather like to keep the patient under mild hyperventilation, which will drive the CO2 out, and that in turn will prevent further rise in ICP. However, excessive decrease in partial pressure of carbon dioxide can cause brain ischemia, and then that may cause swelling and then raised in ICP. So we have to be very careful not to cause too much hyperventilation, and we should keep the PaCO2 level at around 32 to 35 millimeter of mercury. The PEEP should be minimized to avoid venous congestion in the head. Normal saline is the preferred IV fluid because it is mildly hyperosmolar, and then the 4 to 1 formula is used for maintenance of the fluid. Other things that might be worth knowing in the VP shunt surgery include the infiltration of the scalp with LA with ADR will cause analgesia and less bleeding. The proper care of ET tube is quite important, as there is chance of accidental extubation during head manipulation, burr holing, and then tunneling. The head is turned away from the surgeon with a pad below the operative site, and then extreme rotation of the head will impair the venous return through the jugular vein, which will cause congestion and then a raised ICP. So you need to be very careful with the extreme rotation of the head and then subsequently occluding the jugular vein. During tunneling, there is a risk of soft tissue, nerve, or vessel injury. And then again, there is chance of visceral injury during shunt placement in the abdomen. Extubation is done as usual with neuromuscular blockade reversal using neostigmine and anticholinergic. Extubation should be done once the patient is fully awake, so as to avoid hypercarbia and then to minimize the risk of aspiration. Max oxygenation following extubation and suction is to be provided for some time. During the post-op period, the patient should lie supine with the head up by 15 degrees. Analgesic should be provided, and then hydration should be maintained using the 4 to 1 formula, and anticonvulsants should be continued as before, and then antibiotics. Vital parameters should be monitored strictly, and then neurological status assessed using the Glasgow Coma scale. There may be some post-op complications, immediate and delayed complications. The immediate complications could include respiratory distress such as pneumothorax, massive accumulation of CSF in the abdomen, pushing up the diaphragm, and then increase intra-abdominal pressure, and then regurgitation and aspiration. There could also be a deterioration of consciousness, and neurological deficit. There could also be intraventricular hemorrhage due to the surgery, and there is a chance of over drainage of the CSF causing SDH of the opposite side. And then seizure is always a risk. Delayed complications would include shunt malfunction due to obstruction, disconnection, breakage, or migration of the tube, and infection is one risk. Other than that, remote complications like inguinal hernia, obstruction of peritoneal catheter due to occlusion by omentum, or peritonitis, or CSF ascites, and then tip migration into the scrotum, or even perforation of the lower gut from where there may be worm expulsion, and migration of the tip into the scrotum may present with hydrocele. Thank you for watching.